Hello there, and welcome to the True Hope Cast podcast, where we take a deep dive into mental health's many physiological and psychological aspects. This is the show for you if you're looking for motivation, information, knowledge, and solutions. That's what we're all about here at True Hope Canada. True Hope Canada is a mind and body based supplement company dedicated first and foremost to promoting brain and body health through non-invasive nutritional means. For more information about us, please visit truehopecanada.com. Today I've got the pleasure of welcoming Dr. Darrell Martin to the podcast. Now, Dr. Martin is a gynecologist and healthcare advocate with over 4 decades of experience and expertise in women's health. He's testified before Congress championing the rights of certified nurse midwives and patients' freedom to select their healthcare providers. Dr. Martin takes great pride in having played a pivotal role in more than 5,000 births, marking a legacy of life and joy he has helped bring into the world. Today we're going to be discussing women's health and informed consent. Enjoy the show. Okay, hi Dr. Martin, welcome to True Hope Cast. Thank you so much for being with us today. How are you? What is going well?
It's all going well. I'm in the mountains of North Carolina at about 4,000 feet in tremendous weather, enjoying the hiking and all the other outdoor activities that I can do up here.
Beautiful. Well, that sounds absolutely lovely. Well, just as an introduction to the show, we're going to be discussing women's health and informed consent today. You've got a very interesting history, and I'm looking forward to learning more about that and your opinions on many different topics around women's health. But as an introduction, would you mind just letting us know a little bit about who you are and what it is that you do, please?
Well, I am a retired, for the last 2 years, physician, an obstetrician gynecologist by trade. And I practiced from 1977 through 2022. During that time, did obstetric surgery and gynecological visits. Currently, I'm trying to find things to occupy my time over the last 2 years. One of including is I just finished writing a book that was launched in August, and now I'm doing a few podcasts.
Amazing. Can you tell us a little bit more about the book?
The book is called In Good Hands, and it's a book that started out as a narrative of my life, principally because, as I joke, in my last year of pre-retirement, I would share with my patients, and they would ask, "What are you going to do for the rest of your life?" And I suddenly, I'm going to write a book.
All right.
I can't come off the retirement tour like rock stars do and go back singing again. That's not easy to do as a physician. Apparently it's easy if you still have a voice and can play the guitar. But in any event, yes, trying to enjoy my retirement and not say too often in front of my wife that I dislike it, because that implies that I dislike being with her. So that's always a danger zone.
Amazing. And I'm looking at the book right now. If you want to go to darrellmartinbooks.com, you can see that for yourself as well, those people who are listening. And there's an amazing picture there. I just wanted to ask you the question, is that picture from one of your births?
Yes, sir. It is interesting. That picture was taken in 1980, and it was on the front page of the Nashville Banner/Tennessean paper in Nashville, Tennessee, where it occurred. It was the birth that I was required to do because the hospital wouldn't allow her midwife to do the delivery. And so I was then, as the backup, forced to become the primary individual. That is 4 sets of hands, as you look closely at the book. That is the baby's hands, that's the father's hands, that's the mother's hands, and my hands.
Wow.
The only one not with gloves on, well, 2 pair without gloves, the baby and the mama. So I allowed him to help facilitate the delivery in the birthing room. It kind of as a circle of life continuing is when we did the book launch, the couple that are there, the Logans, still live in Nashville. So they were at the book launch along with their daughter, Jessica, who's a little baby. Jessica is now a professor of psychology at Vanderbilt. So apparently my atraumatic delivery went well. So that's the picture. If you look closely, you don't want to look too closely. That is actually the baby coming out of the vagina.
That's amazing. It's so funny because you could have just said, no, I just got that picture off the internet, but there's an absolute gorgeous backstory to it.
Yes, it's a great lead in.
It sure is. And that book's titled In Good Hands, A Doctor's Story of Breaking Barriers for Midwifery and Birth Rights. So I think that, now you were talking about like what you were looking to do after retirement. I think this book is going to support and educate and help a lot of people. So that's wonderful. That's just absolutely wonderful. I wonder what led you into the world of women's health?
Well, I always, from the time I was growing up, I was moving in the direction of medicine, mainly because of the exposure to my uncle, who was a family practitioner in Virginia, in Arlington, Virginia. And his soft-spoken demeanor, his way with people, and the adoration and affection that he received just left a large impression in me, so that I said, boy, I would like to be like that. I would like to be like Uncle Lee. And he's chapter 1 of the book. So that drove me to the desire of going into medicine. What then subsequently led me to do obstetrics and gynecology was the broad aspect of the field, meaning you're taking care often of people for many, many years. So there's relationship building, much more so than, let's say, a general surgeon would have. But yet you see people in the office, you take them to the hospital for the miracle of birth, which is just absolutely incredible, and then surgery. And I enjoyed surgery, and I enjoyed that aspect. And I would often joke, the person who does a back surgeon might see them back again for the back pain. The person who removes a uterus or does a hysterectomy doesn't see them back for another uterus to be removed. So right. There's much more defined work, and it was a lot more relationship building, which I enjoyed.
Yeah, well, that's a really wonderful tale into like why you wanted to go into medicine in the first place from your uncle, but also like the specific area of medicine in which you wanted to be involved in, because it sounds like that community, that relationship building part was a huge motivator for you to get into the women's aspect of medicine.
Absolutely. And taking care of women is a whole lot easier than taking care of men. We tend to whine a lot more than they do.
Yeah, that's very true. I've been to a couple of births with my kids, and yeah, I don't know how my wife got through that, but like I needed somebody to hold my hand through it, and yeah,
absolutely,
it's a miracle without question. And yeah, I think that with the introduction for yourself for the show, I think you've been involved in 5,000 births, and I guess it doesn't get boring after 5,000.
They're all unique. The more elated and the more into the birth the family is, the more you get into it. Mm-hmm. If they're not that into it, then it becomes rote and becomes kind of automatic. Now, I would say out of those 5,000 births, maybe 75 to 80% were me attending or being around for a midwifery delivery, since the bulk of the births that occurred that I was responsible for, the primary person was the midwife. So.
Okay. That's a perfect segue into midwifery. And I'm sure most people listening and watching have heard the word midwife. There's a very popular British show called The Midwives as well, yes, which I think a lot of people would have watched. Would you be able to tell us a little bit more about the origins of midwifery and how it has sustained itself today, and some of the challenges perhaps that's experienced?
Sure. And I think among many other things, probably England and the British Isles have it right, because primary births are either done by midwives or even nurses there, as well as in Japan and some other industrialized countries. But any event, in the early 1900s, if we go back that far, right at the end of the 1800s, primary births in the United States were done by midwives. Well, about that time, physicians become professionalized, in quote. They wanted to have specific criteria for who could practice medicine, so they developed the medical schools, etc. And they professionalized, meaning they licensure, control. And in the early 1900s, there was the decision made to say that instead of birth being a natural event, it was a pathological one. And by definition, changing that, and that was done by physicians so that they could train physicians, because if it's pathological, that would tend to eliminate midwives. And that's where they instituted like scopolamine, which is an amnesiac to really often women don't even know where they are, episiotomies, forceps, all those interventions that were not practiced by midwives. So the number of births never grew with respect to midwives, even until the 80s, 90s, now into the 2000s. And it's about 10% in the United States, which quite frankly, it should be a lot more than that.
And this is the history you've just explained there about birth going from a natural event to a pathological one. You're talking about the US.
Absolutely. Yes. The US, in that respect, I won't say what else it's got wrong, but that's one thing that, in my opinion, it's definitely got wrong. And it was all about power and control.
And what's interesting about that is, like, men often seek that over women, over midwives and over nurses, I guess. Like that.
But yeah, I would say, excuse me for interrupting, but
of course.
In the 1970s, when I finished residency in the late 70s, out of my residency class, there was one woman in the residency class and about 20 men. Now the numbers are far in the other direction. And then by extension, typically, but not always, midwives are women. And again, I am a strong advocate that, still given the choice, the best choice would be to use a midwife for a delivery.
Why? Why do you have that opinion?
Because there's more connection, there's more time spent in the room, there's less intervention by midwives. Typically, they're focused primarily on births, as opposed to obstetricians who might do the sections, would be off doing surgery, would do office visits. So they don't spend near as much time with the client and the husband or the patient herself.
Interesting. You spoke a bit about Britain, and you spoke a little bit about Japan. Like, where around the world do you believe that they have this model, this balance correct?
Well, I think England is an excellent example. Japan does. More of the European countries seem to have the balance correct. Quite frankly, it's about economics in the United States. Interventions provide more money in insurance coverage to a hospital than a non-interventionist delivery. If they leave quickly, it would be less income. If they deliver at home or they do a birth center, it's less financial remuneration to a hospital. And also physicians, by the same token, the C-section rates in the United States are escalating into the 35% number. And the size of babies has not dramatically increased to account for that.
What do you put? So how, of that 35% of deliveries in the US are being done by C-section, of that 35, what percentage do you think is necessary C-section delivery?
Well, I mean, admittedly, there are some complications depending on how high risk a practice is. But let me say, in a general practice, when we were practicing, our rates were below 10%.
Okay.
So, and the more inductions, it's been many articles would say an induction which takes someone to the hospital and starts their labor artificially will at least double the rate of C-sections.
Yeah, we see those statistics in Canada as well. And my children are 5 and 3 now, and these are things we were looking at when we were talking about birthing plans, having these conversations with our midwives, and talking about like a postpartum plan as well. These were things we were certainly having conversations about. So just so I get this right, so once this switch between childbirth going from the categorization of being natural to pathological, when these interventions come in, and the more of those interventions are used, there's more money going somewhere? Like, is there an incentive to use more drugs, more equipment? that, a C-section is a serious surgery. There's going to be multiple people involved in that. It needs the space of an OR. Like, can you talk to us a little bit about that?
Well, yeah, I think, there's a comment that I heard years ago, and this could be respect to any of these physicians, in quote, if the shoe fits, wear it. So if you have a lot of guilt when you hear this, then you're probably practicing that way. I'm not saying all people do, but inductions are typical. Let me use the example at some hospitals here where I live now in Atlanta for the last 40 years. Of a large hospital, let's say that a person goes to a practice and they see a physician, and that's going to be their provider. But partway through the pregnancy, the light dawns on them because they've seen that provider every visit. Say, well, what happens when I go into labor? They say, well, I have a partner, I have an associate who will cover when I'm not there, but I want you. And they'll say, well, I can't be available all the time. I have a family, end quote. So, well, how can I have you? And they'll say, well, I'm on call every Thursday. So if we induce you on a Thursday, then you can have me. So that starts the ball rolling to what's called an elective induction,
right,
which to me should not occur. So often those inductions will start, let's say, at 8, 9 in the morning. And then when they're starting having contractions, then they put in an epidural. And an epidural will allow for a certain amount of control in when that delivery is going to occur. Right? If they're having loss of sensory control and even some motor, they might not know when it's time to push.
Okay.
Well, so the doctor gets out of the office at 5 and he comes over, well, let's get things going. If often by 7:30 or 8, they're not delivered, well, you're not progressing. It's time to do a C-section.
That's a horrible timeline of events.
And it can be one of the reasons why we're seeing such an escalation of C-section rates. I don't believe that the fear of lawsuit is the primary driver for an increase in the C-section rate. You would be hard pressed if you looked at the data that very few times is a physician going to get sued if he does a C-section.
Right.
There are some complications. You can make a hole in the bladder, or you can do certain things, but typically the baby is fine, right? But that may not be true sometimes with a prolonged labor. So there may be that kind of rationale for jumping to a C-section more quickly, the fear of litigation. But just the idea of pushing things along and not letting nature take its course, and any intervention is going to slow down labor.
Yeah, I mean, since I started studying nutrition and anatomy and physiology, and especially the hormonal system and how complex it is within a woman, it only makes sense to me that you would want to work with the natural biological, let's say, surges during labor, rather than throw in these interventions to, counteract these or block these natural remedies, not remedies, but these natural biochemicals that are produced and very deliberately flooding the body. And it just doesn't make a whole lot of sense to me that they would throw in all these interventions to get that baby out safer and quicker. It doesn't really compute.
Well, it only makes sense if you think that it's if they're doing 1,000 deliveries a month in the hospital, it's moving people in and out if they're not in labor for 16 to 18 hours.
Right.
Also, if they have an epidural put in, it becomes more difficult. There are some walking epidurals, but more difficult for people to do, or women to do naturally what should occur. They should be ambulating in labor, and that diameter of the pelvis increases with squatting and being up. Right. It doesn't help to be lying flat on your back or even a 45-degree angle to do a birth. And there's some positions that you can move people around to for any potential complications that need to have that mother have motor function.
Right.
So if you have an epidural, that's pretty difficult.
Within your profession, within your industry, did you find a lot of people, a lot of other doctors shared your opinions on this, on midwifery? Because you've been to Congress on behalf of this, so quite clearly I would guess that your opinion is in a minority state.
Well, let me give you a couple of quotes. Now, you got to remember that I started out of residency on faculty at Vanderbilt from 1977 to 1980, when the real problems occurred that caused me to essentially get blackballed out of Nashville. So some of the quotes back then, which were well documented, one was by a physician said, "There are starving obstetricians in Nashville, so we shouldn't have midwives do births." Which was, it was hard not to laugh when he said that, but he was serious.
Okay.
And then another one that when they were questioning me for wanting to have midwives do birth at the hospital, they said, "I just can't understand why you want to do that. Having a patient question a physician is like questioning motherhood, apple pie, and Chevrolet." And another that caused a little bit of laughing on my part, which was not helpful at all. But it was so intense that they ultimately, when they couldn't push us out, because to stop midwifery, you either block the policies and procedures of the hospitals. You require women, for example, to not walk. You require them to do certain things like preps and enemas. This is back in the 1980. Or you attack the physician. A physician is the supporting arm for the midwives, and if you attack that person, then you've effectively eliminated the midwives. And that's what happened. They pulled my malpractice insurance in the fall of 1980, and that involved all the litigation, the congressional hearing, the antitrust lawsuits. Now that took 13 years for that to resolve, from 1980 to 1993.
And what was the resolution there?
Well, we won. I mean, we won that victory. It was very helpful. Let's say if you would speak to the midwives in that era, there were multiple attacks on midwives occurring throughout the United States around 1980 for the reason I've described, because number one, there's never been a study that showed that midwives are unsafe. Okay. Never been one. So they can't use that argument. And so all these attacks were occurring primarily at the physician, because without the physician support, then it becomes very problematic for them they can't work in a hospital. And so all these attacks were pretty effectively stopped within 2 to 3 years of 1980, when we had a Federal Trade Commission antitrust lawsuit against the malpractice carrier. And so that stopped a lot of the attacks in the United States at that time for a period of time. So it was a big win for midwives, and the congressional hearings helped for that. And the litigation helped for that as well, because they lost and they admitted guilt.
Wow. And then how has the state of midwifery gone on from there?
I think it would be by location. There are some states where it's still difficult, extremely difficult for midwives to work in the United States. There's other states where it's much more open. So it's a state by state issue in the United States.
Okay, interesting. Okay. I'd love to talk more about the kind of the system that you've been involved in, the systems that's kind of controlling all of these, and you've been challenging these established norms to pursue a more compassionate and effective healthcare system for mothers, for parents, for babies coming into the world. Where do you think these systems have gone wrong?
Well, for one, would be the training of medical students and the physicians who are going into obstetrics and gynecology. If there should be some method of collaborative training where they're getting some of their training in normal obstetrics predominantly by midwives, so that the people, the professors aren't just telling them what to do or what might be an option, but they're showing them by example. And the best example would be to be taught non-interventional obstetrics by midwives. So that would be the way to ground all of the physicians into in any specialty for that matter, the importance of collaborative practice. You see it in the United States a lot, for example, with anesthesia. There's many advanced practice nurse anesthetists and anesthetist people who work with anesthesiologists quite well. And there you have family practitioners and family nurse practitioners who work quite well. It's not been as predominant in the field of obstetrics, at least as a percentage basis. And anytime there's a big pie to be divided, if you're in a community, and I call the pie the number of deliveries, right? And so you get your share of the pie. To me, it should be based on the kind of care you give, right? People are drawn to you because they're seeking this kind of care. So that can drive the bus, so to speak, for women by them being educated and them demanding these kind of services. And then the physician groups are going to have to decide, am I going to join the team or am I not going to join the team? And economics will drive that bus.
Mm-hmm. When you were studying this, what was your recollection of learning about this?
Well, I learned first some of the wrong things to do when I was in medical school. Literally, this is a true story. I was watching as a second-year medical student, obstetrician do some births, and it was commonplace to use a drug called scopolamine back then, which is an amnesiac, and women just don't remember anything, and they can say things they probably shouldn't say. And I walked in on a lady who had a dose of scopolamine and found her under the bed barking like a dog. So that experience said, first you look and then you're quite taken aback. Mm-hmm. And it's sad. It's really sad. So the empathy occurred at that point for me. And in medical school, we didn't have the fancy monitors, so we were listening with doptones. So we were hands-on board with the patient sitting next to the bedside. Yeah. And so that allowed much more engagement. And it was tremendously rewarding to not just be a technician, so to speak, but to be really engaged with the family, getting ready to experience in my opinion, one of the greatest things you can do in your life is to experience the miracle of a birth. There's nothing that to me can top that of all the other experiences I've had. That is incredible. So that would help. And then I think consumers should drive the bus. They should get educated and don't believe the hype that it might be more dangerous. Right. Because that's fear. And I often encountered in those early years, wouldn't necessarily be the future mother. It might be the future mother's mother or the grandmother or the mother-in-law or the father who didn't really understand and were immediately discounted. Oh, you must use a physician because that's safer. And right. that was propagated by physicians, right? So that they could not have this system in place.
Interesting. I think the themes of control certainly come up in regards to these physicians looking to be able to, I guess, dominate the whole birthing industry.
Well, it's admittedly it would take more time in a visit to actually engage and interact with someone rather than just arbitrarily tell them what to do.
Yeah. And I feel it's very challenging for probably physicians all over the world at the moment to be able to have the time to kind of formulate those relationships with their patients and to be able to create the time and have the availability to be at the birth of each of their patients, like you mentioned earlier about a physician, scheduling in that they're free on that Thursday and they could do the induction that day. Like that's that doesn't quite sound like the one of the reasons, like for example, that you got into medicine, for that relationship building.
No, I quickly found, because of working with midwives in medical school, well, in residency, essentially, that was just a better way to practice. I can't be all things to all people, and I have other duties that I'm torn to do. And I said, I used to joke with patients and they'd say, well, do I have to pay more do I pay more? Do I pay less because I'm having a midwife? And I say, well, actually, you're getting 2 for the price of 1. So you're getting a better deal. And they say, oh, that makes sense. That makes sense. And so safety would always be an issue, usually with everybody besides the mother. That would come up from the people who weren't really engaged in the process, because the connection was built between typically the physician and the patient or the client.
Yeah, we had a naturopath on the show very recently talking about pregnancy and postpartum and the preparation in regards for both of those things. And the key takeaway I got from that was having a good quality community around the birth and the planning of that, and having the partner, the mother of the mother, like involved in being able to actually make decisions in the absence of the parents being able to do that, and just having everyone kind of on board, as not just as a support system, but to have, like when everything doesn't go perfectly smoothly, to have, a little bit of a procedure in place. Have you seen that be an effective way of going into birth as well as postpartum?
Yes, I've seen, and we use a term, I don't know if it's a similar term in Canada and Great Britain, but doulas. Doulas are usually paid. They may be a friend, but they're paid to be the advocate for the couple. So if things are getting a little tense, that person can step aside and really engage and be the advocate with the caregiver, right? I've often found that the more trust you build during that 6 or 7 months, however many months that you're seeing them in the office, leads to a much smoother labor and delivery experience. There are times when you have plenty of time to explain the rationale for why you're advocating something in labor. And when you have that time, if you've built a relationship throughout the pregnancy, there's a lot of trust there. There's a lot of trust, as opposed to someone who walks in the room you've never seen before.
Yeah.
So you have to have that trust building before you get to that point. And then there are times then, because they respect that trust, if, those rare occasions when the heart rate bottoms out and you've got to take them back and do something, they trust you.
Yeah.
And there are times when you don't quite have enough time to totally explain what's happening. They understand when that heart rate bottoms out that something is happening. So that trust that's built up over a lot of months, I think, is essential for a great experience. And the last thing I'd say with that is, some people there should never be an advocate in the room that perhaps at the end makes the mother feel guilty.
Right.
She wants this experience to be how she has in her mind and how she studied for. Sometimes it doesn't work that way. And sometimes a person can push her a little too hard into doing something that, if she doesn't accomplish it, then she feels guilty.
Sure.
And we know that the ultimate outcome is just a healthy baby and a healthy mother. How we get there is based on how we relate to each other.
For sure. Yeah. I mean, it's obviously, for mother and father, it's a very, very vulnerable space to be in, and having to make decisions very, very quickly. Being in that position is very, very challenging. I've experienced that myself. But to have it, we had a doula, I had a midwife, but both of our births, and we had these people who knew our plan. They knew they knew what we wanted to do, and they were able to make decisions on our behalf. And yeah, I'd highly recommend that to people, to have that circle of individuals by your side. And I think historically, if you look back, that would be a very typical way in which we would give birth, as a community. I'd love to talk to you about informed consent around pregnancy, around childbirth. First of all, would you mind telling us a little bit about what informed consent is, and kind of wrap that into your wheelhouse?
I think, to explain it as simple as I can in lay terms, it's trying to explain all the risk, benefits, and potential complications that might occur in the event that's going to happen. And in this case, a birth, or subsequently a C-section. You see, just an aside, you go into a hospital and you sign your life away with a bunch of forms that you're never going to read, which if you don't sign them, nothing's going to happen. You're not going through the door. So, and you don't understand all those papers, but you do the best you can to inform them of the potential that this is not always a perfect event. So that's informing. Now, there was an interesting study done years ago, and it was on cardiac surgery, and they filmed and recorded the informed consent for every person who was having that cardiac procedure. They then talked to that patient 6 to 8 weeks later and said, "Were you told this?" "No, I was not told that at all." And I was told. And then they showed them the film where they actually were shown that, yes, every one of those things that they didn't think they heard,
sure,
they were actually told. So there's a lot of anxiety when you're hearing that. How much of that are you hearing and taking in? So
interesting.
I think no matter how much informed consent, there are plenty of litigations that, fortunately, I never was sued as in the 40 years of practice and lost a lawsuit. But often informed consent is one that a plaintiff's attorney will go after. Well, that wasn't really fully explained to me.
Okay.
They just made me sign some papers, and there's a lot that can go wrong. I'm sure you've seen, I guess there's commercials for medications that you see, like we have in the United States, and they'll say, these are the benefits, and this is why you should take this medicine. And then there's somebody coming on for another minute who lists about 45 complications that could potentially happen, including death. And you begin to wonder, why do you even want to take a chance and take this medicine?
That's only after the beautiful imagery of the old man running through the field with his grandchild playing football or something. Yeah, I've only ever seen them when visiting the US, because that's not allowed on TV.
Yes.
Anywhere else,
it isn't. Yes, that's ridiculous. It's ridiculous.
But yeah, that's a very important point, and it's usually like read out at ridiculous super speed.
Yes,
so nobody's able to actually compute that anyway, because it's not like how people talk.
No. So that's a difficult one. I mean, you do your best you can with, and I think from a obstetrical point of view, it would be, here are some things that could happen that may require you to have a C-section.
Right.
And some of them go away before you get there, like you don't have twins or triplets, you're not in preterm labor. But most of the time, before you make a decision to move in a direction, you're allowed to redo more specific informed consent.
Yeah.
As opposed to general informed consent.
Beautiful. Just before we finish, I really want to talk about your book as well, like who that's for. But I would love you to just, in your experience that you've had, what are some of the like vital key roles of a midwife?
Well, first, education. First, it's education, ideally with the visit before they get pregnant, so that they're preparing them ahead of time with education, with nutrition, with exercise, and then it's labor observation. It's not, nurses are good, labor and delivery nurses are very good, but often you'll see physicians will still be in the office and maybe order an epidural. They might not see the person necessarily until it's time to birth.
Yeah.
And they're expecting that nurse to let them know if there's a problem with the heart rate, or they're trusting them for, are they progressing into dilation, as opposed to the midwife who's there all the time.
Yeah.
I mean, that's their job. You know, they don't have other jobs. That's their job. And so that it makes so much more sense, you know, to have a midwife there, and even a doula as well. You know, I think that not the more the merrier. That's probably not a good term, but the more informed people there.
Yeah.
You know, a mother-in-law is probably not the best person, or a mother, because they're so emotionally tied in.
Sure.
To be that kind of person. You know, I get disappointed when I see, I don't mind if there's 3 or 4 people in the room, but I don't see the point of them sitting in a chair in the back just observing.
Sure.
You know, that's they might as well go watch a movie, you know.
It's a participatory role for sure.
Yeah, absolutely. It's for participation.
Yeah. No, I think that's wonderful. And I think, yeah, the idea of having a midwife, somebody who's got that education, somebody who's got that experience, like if I have the choice of jumping out of a plane with somebody who's doing it for the first time with me, or somebody who's done it 5,000 times, I'm going to strap myself to that individual every single time. And it's so vital to have that. I think that experience, but that calm in the room when things, you know, when things might get a little bit intense for you, especially as a first time parent. So vital to have that calm in the room, that patience in the room. You can't really put a price on that to have that as an option.
Absolutely not. It's a team event too. I think I would often, even though I wasn't going to be part of the delivery, I would go in and meet the family again, or maybe for the first time, meet the extended family. So kind of allay their fears. There's someone here. If there needs to be someone here, we're here to help. And that anytime you can reduce anxiety, you know, anxiety and tension, in my experience, in labor slows down labor. That's a big muscle that's got to work there. That uterus has got to work in sync. And when there's other stressors going on, that doesn't let it work as well.
Beautifully put. Yeah, that anxiety piece again is absolutely huge in regards to like what a woman can and can't do with their physical body in that moment. So back to your book, can you tell us a little bit about who that's for? Is it is it a memoir? Is it something people can obtain to learn from? Like, how would you describe the book and who it's for?
Well, it is a memoir, and it started as a narrative from the day I was born until I retired. The principal part and it was meant for women and for my patients, but it does teach the experience of choosing a midwife and why, and how the medical establishment can block that, and why, and how you can make some informed choices to move in what I would consider a better direction. So it tells the bad, what happened to me, and then the good that came from it, in the context of why I got there. I mean, the first part of the book, first few chapters, is how did I get to be an obstetrician gynecologist?
Well, it's an interesting story, and I think that any book that's helping people educate themselves around the idea of midwifery and how they can actually advocate themselves to have that as a part of their birth, I think that's absolutely wonderful. And yeah, if you get the opportunity to get to darrellmartinbooks.com and check out even just the image, and then listen to the story of Darrell explaining the importance and beauty of that picture, is very, very worthwhile. But thank you so much for coming on and sharing this information with us. I think I was generally super, super excited to learn more from your perspective in regards to midwifery, because there's not many people out there in your position talking about the importance of it. So thank you so much. Is your website darrellmartinbooks.com, is that the best place for people to learn more about you and get hold of the book?
That would be one way. The book is available on Amazon, like everything else is in the world.
Right.
We in the United States can order anything on Amazon and have it delivered to our front door. And it's in all the major bookstores. But yes, my website then leads into the Facebook page, and there's a little bit more information. But yeah, it was something that I just started one morning and worked several hours a day for months. And the person who helped me write it had to reduce it from 125,000 words to 65,000 words. So,
oh, wow.
So some of the stories, some of the hilarious stories, may be coming in another format in the future.
Maybe in the shape of a podcast. That could be cool.
A podcast. I would go for a movie as well.
Okay.
Yeah, we were actually approached to do a movie in 1981, but that was just the beginning of the story when everything fell apart. So now it's maybe the ending is better than the beginning. So we'll see.
Well, it could certainly make for an interesting documentary. I think a lot of people, not just people who are looking to have babies, but people who are strong advocates of the practice of midwifery and doulas and the informed consent for mothers. It's a hugely popular topic. So I think that you would not struggle for eyes and ears whenever you decide or however you decide to do that. So Thank you again, Dr. Martin, for coming on the show. I really appreciate your time today.
Thank you very much. I enjoyed it immensely talking to you. Thank you.
Beautiful. Thank you. Well, that is it for this episode of True Hope Cast, the official podcast of True Hope Canada. I will share links in the show notes if you wish to connect with Dr. Martin or grab a hold of his book, which I highly recommend that you do that. I'm going to do that as soon as I finish up here. But you can leave us a review on iTunes if you want to. You can leave us a review on Spotify. That is it for this episode. We'll see you next week.
Thank you. Thank you very much.